Grounded in research, individually focused, and back at last. Welcome to the Thriving with Stripes podcast.
All right, welcome back to episode 5 of the Thriving with Stripes podcast. Today, it is all about POTS doesn't come from nowhere.
POTS does not come from nowhere.
My name's Tom Stott, sitting alongside Dr. Patty Stott, and let's just get right into it. Where does POTS come from? Can it be sourced from one spot? Is it from any number of causes? Where do you want to start this conversation?
That's already jumping right into it. I will say I wanted to bring this up because I try to avoid social media for these reasons because things get me fired up. And I was looking at a social media post. Not if you're going to look this up, it's not from where I am currently located. I happen to be a member of different groups, and it floated through my vision this morning of somebody that had said that they had gone to a more holistic naturopathic type doctor. And when they brought up their POTS issues and that they weren't being managed well through kind of our standard means that they were using, the doctor said, well, if it's not being managed well through our normal, electrolytes and things like that we use for POTS, and it is probably coming from somewhere else, that we have to look for other things like, let's check your hormones and let's do this and let's do that. And she said that she felt uncomfortable with that because she hadn't heard of that before. And I know people don't want to go down rabbit holes. So she had posted for some feedback. And this is where I get a little fiery because within that group, a naturopathic doctor, and I know this because they said licensed naturopathic doctor here, said that that was just a lie. And the words were so strong. This doctor doesn't know the scenario of the patient or all the details. So to just outright say, that's a lie, PUTS does come from nothing. No, it comes from lots of things. It can come from your hormones. It absolutely can. And then to further go into that and say that they are an EDS expert, so they know that, no, you just have to work on your POTS. I'm like, oh my gosh, actually, no, deeply no.
I feel like this is a recurring theme, thinking that we're past this point.
I always think that we're past this point. In fact, it hurts my heart a little bit because I work with this group, right? Like this is my patient population primarily, and primarily the neurological or neurovascular phenotype of hypermobile EDS. And we worked on a paper. We worked really hard on collaborating internationally on this paper for upper cervical instability, where in that paper, it says that one of the signs of upper cervical instability is POTS that poorly responds to regular treatments, which means UCI is a cause of POTS for some people. So yes, your POTS can come from other things. You shouldn't be treating it or trying to treat it or just give it more salt or give it more water. No, to a certain point, but there are other things to look at. So let's start talking about those other things today. Like you started to kind of go down the rabbit hole, so many other things to think about if somebody has POTS. And I'll pause let's rewind a little bit more because I think people get stuck in POTS. Oh, there's so much research on POTS. Well, POTS is dysautonomia. And this is where I have a problem with labels, is because if somebody has POTS, they have a form of dysautonomia, which means a dysfunction of the autonomic nervous system, which regulates all of our automatic functions of the body: pupil dilation, sweating response, your adrenal response, digestion, gastric motility. Your autonomics regulate everything that you're not supposed to be thinking about. And when you have part of that be an abnormal heart rate response to positions basically going vertical, we call it POTS, but it does not mean that there isn't anything else happening in any other area of your body. So I don't like to get hyper-focused on a diagnosis of POTS because we might be missing that somebody has gastric motility as well. And we have to go a little bit deeper into what we'll talk about. Why does somebody have dysautonomia or dysregulation of their autonomics? That is the important question.
Yeah, I think a couple things to kind of consider when we look at the spectrum of the presentation. And I like the language that you use. And I think when you did have a pretty fire response reaction to what you read this morning, one of the things that we were quick to kind of point out as we were talking with each other is that we want to be more inclusive of ideas and solutions and routes to go on
Right.
rather than exclusive and right away saying there's no possible way. Like that feels ignorant to me.
Well, I also have a problem, with the bad mouthing or using, like, that bright language about other providers that you know nothing about. Like, just saying, "That's a lie." Well, you don't know what that provider had in store. I like to think everybody has magical superpowers out there, like, their own individual things that they specialize in, so we just don't know until we know more about it. But you can't say that without knowing the situation of the patient or the provider. So I think that the problem is that there's actually so much to offer somebody that has dysautonomia, like a bottomless pit now, whether we're talking about things on the commercial market or like neural retraining or God, so much stuff that we could talk about. But today we'll talk about where it comes from.
Sure. Um, yeah. So where would you like to start in that
Well, let's
regard?
start with the people that are going to say, well, no, you can be born with dysautonomia. Yes, you can. You can have the genetic predisposition, just like s- the forms of Ehlers-Danlos syndrome and also this hypermobility spectrum disorder and HEDS. We will find that there is a genetic component that increases the risk of altered connective tissue structure or repair,
And
right?
this could come from any layer of genetics. We could be looking at vasculature and like blood vessel connective tissue. We could look in within the heart. We can look outside into a different space
Well, it
and
depends on
around
like
neural coverings.
what collagen is impacted or what protein or what enzyme. It's the extracellular matrix component. I think that was episode 2. So more in there about that, but yeah, it's the same for the autonomics as well. And we're such babies in understanding genetics. So what I'm saying now, there's in 10 years, there's going to be so much more information. But we know familial dysautonomia and then hereditary sensory and autonomic neuropathy with spastic paraplegia is also one that has genetic components, which means that you were born with a predisposition to altered autonomics, a predisposition or an increased risk. But genetics don't work by putting a stamp on you. For most cases of genetics, it's about this expression piece. So I do like to know that information because I do feel like, yes, the people that are born inherently with this increased risk and have the genetics for it, those are the people that I do want to know all of the strategies for general dysautonomia treatment and then all of the rabbit holes that we have out there of tools and modalities because those people would probably need to rely on those things consistently at times throughout their life. So there is a genetic component, yes, but this blaming it on EDS again, go back to our second one. The problem with the trifecta, this MCAS, EDS, and dysautonomia or POTS, is the problem with inflammation that has not been controlled in the system of connective tissue, because that's where things are filtered. So again, this isn't a different episode, but it's redundant because when you have a problem filtering out inflammation, your mast cells will become confused and hyperactive in that area. And your autonomic nervous system endings are in that area on a feedback loop. So you're going to get altered activity. So if you have the genetic risk factors for a hypermobile EDS or an HSD presentation, and you've tipped the scales on inflammation and have not been helped in that sense, then you're probably going to have mast cell activation syndrome and dysautonomia because your connective tissue cannot filter the inflammation out. And it's making things very confusing for your system. So that's why they all kind of go together. It's not like you just have POTS because you just have POTS. You have POTS because something triggered an inflammatory autonomic event in you, and that's where you have to sit down with the person and say, what was yours? Or I should say, what are yours? Because it's never one thing.
Sure.
There's usually a trail of breadcrumbs for an individual.
And then what are yours? And I always like to frame things through the lens of a story. I think for my brain to comprehend things, but also to show the patient that we are moving like through something still. It's not like the story's ended. I have this, and it's there's no way out of it. There's many ways out of it, like you just
Mm.
pointed out. And considering like, how you enter it just is one, I think, validating to, I think, understanding why I feel like I do right now when I've been kind of managed, but making it, most of the way through my life for the past 10 years. Why am I so bad right now? I think it's good to have answers in that regard. And not that we need to get hung up there, but to show us where we're going to go from and maybe lend a possible nod towards triggers to avoid for next time.
Right. And that's the thing is triggers, but I feel like the list of triggers that we have,
It's
uh,
endless.
well, it's endless, but like it gets so specific that
Sure.
like when you look at the list, and I'm guilty of this. I do a lecture on dysautonomia every year with the Echo Project, and the problem is we have so much to talk about. When you look at the list of triggers, it's like heat, cold, like it's very specific, and then you have things like stress, past trauma, systemic inflammation. Those are bottomless pits in and of
Right.
themselves, and that's where the majority of our focus should actually be because I do I feel like some of those other things are actually much more easy to avoid or to retrain. But when you're talking about like these viral episodes that people have, they're really difficult to clear out the viral loads from connective tissue and also reestablish normal function of connective tissue and neurological communication. That's a lot to do. That's what, like, thanks COVID for showing us that viruses can cause continued issues with connective tissue and also with neurological tissue and dysautonomia. Like, it's all over the research now. Like, people know more about POTS because of COVID,
Sure.
really. So when you're saying
And
no,
or I would also add like mast cell responses too because of
oh my gosh,
COVID. Yeah.
sure, sure. And that's the whole cycle of
Yeah.
that inflammation problem, that neuroimmune inflammation that happens with altered connective tissue structure. So yeah, it's kind of like we're still talking all about the same thing as these inflammatory loads. And yes, like chronic stress and past trauma, which causes neural rewiring, can also play a role in this. So it doesn't come from nowhere. You don't just wake up one day and poof, you have POTS, and the only thing that you can do is what I call the tools that are mops, where we're not turning off the faucet, which is the problem that's causing the leak. We give people water and electrolytes, and which is great for symptom. I love symptomatic treatment. But if we're talking about regulating from really this neurological level, we have to go back to understanding why did you just have this flare up, or why have you had a chronic flare up since, yes, hormones can play a role since menses started, since females have their period. So much that goes into this. And to just say a blanket statement of no, POTS doesn't come from hormones. I'm like, oh my gosh, there's research on this.
Yeah. What maybe thought in considering presenting on dysautonomia in the future, maybe that chart of triggers, contributing factors, maybe instead of just like contributing factors, colon, bop, 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 maybe it's contributing factors, and then below that, a cumulative load from, and then all of them. Maybe it might
Sure.
help people like frame that it's usually never one, it's usually most or all, and but just to get the fact in on that load piece.
Yeah, or like a catalyst to the equation.
Yeah, I know some extra words in there. I know people they see lists and it's easy to gravitate towards them and kind of pick and choose, but we really need to reframe the conversation to be more inclusive and viewing, looking from 30,000 feet type of deal.
Yeah. Yeah. I mean, we can go through if you want to go through some of the specifics like we were talking about and just pull them out for people too of where does POTS come from?
Yeah,
Like what are
let's
the main things that can be contributing factors? And I'm not going to start with I think it's like the acute versus chronic response that we're talking about. Like, yes, you can have an acute response to an extreme cold exposure, an extreme hot exposure, but your system should reset. So, what are the things actually that are, filling the bucket or more likely to overflow the bucket? Those are the things that we should be talking about a little bit more. So, maybe we can focus on those today. Happy to talk about like maybe of course, we'll talk about like cold exposure retraining, which I think is extremely helpful as an end goal for people that have temperature control problems after this chronic underlying dysautonomia is controlled. Um,
I I I also work in a population with normies or people that are on that spectrum of like I have some of this stuff, but it's not turned up. And I see a lot of temperature control regulation issues that are very much like grounded in autonomics that,
Sure.
this goes across the board to all humans, the human existence right now and stress load and
So let's start with stress.
yeah,
Okay. Because I feel like a decade or two ago, like we finally recognized everywhere like stress is a problem, right? And then it just kind of dropped away. And we're like, okay, it's a problem. Have a nice day. I guess we'll figure it out at some point. But we don't figure it out unless we talk about it. And stress within this population can come from so many different factors. So it's really an independent solution. Sometimes it's huge changes that somebody has to make. And sometimes those changes can't be made. And we hand you a vagal or cranial nerve stimulator to get you through it. And talk about neural retraining later. So, but stress is huge. Stress is one of those things that I think is a primary driver. I talk about primary driver versus catalyst a lot with my patients. Viruses are catalysts, exposure to mold are catalysts, like these things that drive, and like we really have to work on them. But primary drivers for a lot of people are this chronic or acute stress load, not happy with your jobs, struggling with a relationship that you're having, your medical trauma that you're going through, and stress trying to get your own care managed. I mean, it's so difficult with this population to find the right people to help you out. It's super stressful. And to just say, well, just go ahead and manage your stress. That's extremely layered.
sure. So considering, you know, like a couple of those things you mentioned between job and relationship alone, those are big, like daunting topics. Like, how do I change or go about that? Do you approach those in a space of like thinking support first before change? Or like, how do you kind of approach that dynamic?
Depends on the person that I'm talking to, right? It depends on the person.
Yeah. Like, do they, it's, I'm sure you meet somebody and they're just waiting for somebody to not give them an excuse isn't the right term, but that little nudge, that safe space of like, you can do this and this could help your health. Your gut is right. Like some affirmation is what I was looking for.
Right, right. And I'll tell you that anybody that walks into me and says, I hate my job, I am going to start to fully support your life change in that. But also understanding this is not something that somebody can walk out and quit their job and like everything's hunky dory.
Right.
And like there needs to be a plan set in motion for this. Those are things I do like to know sooner rather than later. It's not always the first conversation you have with somebody because it can be
Right.
super stressful if you go in, you're like, I'd like to learn about EDS. And we're starting to talk about moving and, and like changing your job. That's too much. But there are people that walk in and say, I know that my job is not helping me. Okay, great. So we need to talk about
How are
this.
we
And
going to support it right now since you
yeah,
can't change it right now? And then what's the plan?
I have had people that walk out and quit the next day. They bring it up and I'm like, okay, we've got to address this at some point. And they're like, I quit. And I'm like, I'm so proud of you. Okay, we still got to figure this out. And I have some people that come in and say like, and I'll be honest, I'm one of those people, right? And I love my job. And like as an example, I keep thinking of this other person that I work with who loves their job. Um, but it's so stressful. This is a really stressful job. I'm not going to hide that fact. I love what I do. I love the people that I work with, but the people that I work with, it's really difficult to get them the care needed. Me as a provider to facilitate that too. So this is really stressful. So I'm not going to leave my job. This person that I'm talking about isn't going to leave their job. So we use all the tools and things to help manage. And again, my favorite right now is the cranial stem that I use. But I have a bunch of other things at home and I do
You
mindfulness and
currently are
meditation.
wearing a PEMF
Oh,
pad,
I
right?
am. I'm wearing a frequency specific microcurrent device, a PEMF pulse electromagnetic frequency device. Um, at the end of a workday, sitting down to do a podcast to get me through it with some extra coffee. So I use my tools, right? Because I don't want to walk away from my job. So it's an individual conversation, but stress absolutely has to be talked about at some point of how we're going to manage this because stress 100% drives autonomic dysfunction. I don't see how it cannot. I mean, it's science. It's biology and
Right,
science.
yeah, I'm on board with you.
Right.
I feel like stress was kind of a big piece 10 years ago. Sleep joined the equation like 5 years ago, but it's hard to kind of have with everybody's individual situation, like, here's what we do. I mean, we still don't know enough that we need to know, but we kind of understand sleep cycles and the importance of deep sleep and then shifting into rapid REM sleep
Mhm.
and kind of with our understanding of from a lot of these wearables, you have an Aura ring that we've tracked some sleep stuff.
Mhm.
Um, I feel like it's gotten a little bit easier to gather data on, but it's still like, what do I do with that? Where do I go? I think that's where kind of this next nudge of
Yeah.
where science is headed. So stress and sleep, I think, are so paired close. Do you want to
Yeah.
talk about? Do you want to shift on to sleep a little bit?
We can shift on to sleep. I still think that's reflective of the
Kind of the
autonomics in
stress load.
general, like the
Yeah.
stress load and can be influenced by viruses and all that. Because when we sleep, as you're saying, we go through these cycles. It's really the body transitioning as we go through the different phases of sleep, kind of like the different layers that we have. We're shifting from parasympathetic to sympathetic, back to parasympathetic. And it's like this wave that happens that actually shifts and changes and stretches out. So we start with shorter waves. And then as we start to wake up towards the mornings, the last few hours, it is more of a sympathetic, um, toward driven response. So it's hard to regulate if you can't regulate your autonomics, it's really hard to make all those transitions at night in sleep. That's what like we're horrible at transitioning, being able to transition from sympathetic to parasympathetic and back because we don't have the strong braking system for the parasympathetics. So very hard to sleep and be rested if you have dysautonomia, period.
So
So
then in that case, sleep becomes not necessarily like a a target to approach, but more of a
sure.
reflection of where we're at
You
and
got
how
it,
we're
and
doing.
that's why, like, I'm happy to talk to people about sleep hygiene, but to be there's so much stuff, right? Like, I feel like that we talk about that happy to talk about like, food, same thing with food, happy to talk about this stuff, but honestly, if we work on some of the other things,
Do you remember how much we used to think it was like
all
all
food,
food?
all food, like, let's just
What a bunch
change
of
your diet.
rookies.
Rookies. I love talking about food, and I love talking about the
Also
positivity
not
of food.
minimizing the impact of food, right?
No,
Like,
no, right,
I
but it
get
was
that,
like
but
yeah, it was like, "We can control everything through food." Well, my neurological inflammation disagrees.
yeah.
But yeah, so I think it's a good, feedback for us to be able to see, like, is the work I'm doing improving my sleep? And yes, like, if you're doing a lot of screen time and your sleep habits are horrible intentionally by your own measures, sure, let's talk
We
about
need to
it.
make some
Yeah.
obviously, like, low-hanging changes that will be impactful.
Yeah, but still not the reason for
Sure.
dysautonomia. Unless you're intentionally sabotaging your sleep cycle, which we're all like at some point in our life we do, right? We want to stay up and read the book or just stay up late just because we don't want tomorrow to come. So so it happens.
'Cause you feel like you didn't get to enjoy or relax enough in the day. So we need to relive a little bit more to be able to
We do. We have
li
this problem in our house, not just with me, but I've passed it down a generation. It's the fear of getting to the next day without fully enjoying the first one. It's tough. It's a tough place to be.
Okay, so let's stay on just stress as a topic. I know relationships are a big piece of it, and when we say relationships, it could be something like a partner, it could be, friendships, it could be familial, coworkers, like, all of these things fall under
Oh,
this
sure.
umbrella. What I've noticed, the just that desire to not even be validated, it not even understood, just before understood, maybe heard, or just like that there's an inkling that there's a possibility that they might just start to listen is kind of where I do some support work with families. Um, Not trying to teach empathy or to get like fully into that space, but just to say, hey, this is kind of how hard it is.
Mm.
Do you find like the understanding is kind of an entryway to talking about relationships, or where do you like to start?
Um, yeah, I mean, I have more experience in working with like the person or patient directly.
Mhm.
And I have worked with families before, but it tends to be more from what they need as an individual. I know you work with families a little bit more than I do. Um, but yes, I mean, that's certainly part of it in a relationship part. And we're going to talk about this is the next podcast, actually. That's
Sure.
why I'm like, I'm fighting back words because we're going to get into this next time of kind of the understanding from family members and just defining this a little bit better as like a message to family members. I do think that that's important, and the validation is really important. I think the example that I use for about the relationship piece or just the stress piece in general is, and I have seen this over and over again. The two main things that I think a lot of people can understand in in this population, unfortunately, is working through disability and working through a divorce. And those are things where I think we know how stressful that is for people. Like it really, like it, you wear it like a weight, and it's really hard to support yourself through it. And as I'm working with people getting CSF patches repaired and working through this neurological tension and tethering that's happening and all of these things that they really want to make gains with, but they're under this heavy load where they have no control over the timeline. And that's where I think the stress piece gets to people is the control part of it. Like relationships, even I feel like that you might have a little bit more control over that. But if you're dealing with disability, it's usually a very long unknown amount of time that we just don't know how long this is going to last for. And there might be a denial, and then we might have to go back, and we might have to get lawyers involved, and it's really, really stressful, and I don't have a timeline. And I had to say, just hang in there. There's things that we can do to support
That
more
cat
passive.
poster in every middle school counselor's
Hang in
office.
there. Yeah, yeah, the cat hanging in there. There are ways that we can support. And then the same in people working through a divorce or a move or whatever it might be, that you don't necessarily control that timeline, right? And it's like such a huge weight that's sitting on you that you don't know how it's going to end either. Those are the big type of stressors that we can also offer some passive supports. And these mops are great. Like I was talking, all these tools are great. But until that stressor passes, you're probably going to have neurological instability and dysautonomia. It's a lot for the neurological system to process, just constant just weight of dealing with those stressors. So those are the main ones that I see. Like relationships, yes, but from the idea of not knowing the timeline with those relationships, I think that's what takes the control away from people,
Sure.
and that validation piece of like, when are we going to get through this? Just let me know when we're going to get through this.
Yeah, I think having the way I like the way that you frame that because it kind of gives you a pass to be a little bit dysregulated at times. Like not a pass isn't I guess not what the word I'm looking for, but it kind of gives you some assurance that you're not wildly crazy for being in this state, given all that's in front of you right now.
Right. Oh my gosh, yeah. Yeah. And that's one of the hardest places to be completely honest, is having something that you have no control over the timeline and you're kind of caught in it. You can get through it. There are things to do. There are supports to be had. Tell you if you want to move on to the next one, viruses are easy to deal with, even though I know that there's a lot of people dealing with a lot of like post-viral POTS and you know long COVID and things like that that affect the neurological system. But I still find that easier to manage than an unknown timeline and an unknown amount of stress coming from personal lives like that.
Sure.
Yeah.
So just overload the passive supports, the treatment strategies that have been beneficial and that can work for people in that space of that unknown timeline.
Yeah. And be that cat poster, hang in there, keep your nose above water. That's just nose above water until we get there. Yep.
All right. What's the next layer down then? So
So, well, I said viruses, if you
yeah,
want to talk about that. And I think that's kind of the hot topic now. Like I said, thanks COVID.
sarcasm.
A little bit, right? I mean, that's we as humans, when we learn, we need to learn from strong things to shift the way that we think about things. And, there's been a little bit of foo foo on the subject for decades within the more natural fields, talking about pathogens and toxin exposures. But no, they're absolutely a thing, and they are filtered through your connective tissue. That's where it happens in the interstitium. So the reason, and we could talk about mold, but I'd rather talk a little bit more about viruses. And the reason why is because viruses are known to be more likely basically to break through blood brain barrier and neurological tissue and irritate neurological tissue, which means things like the brainstem, peripheral nerves, cranial nerves, things that communicate with the autonomic nervous system.
I think like, can I pause for just a second?
Mm.
Can we just bring up like shingles? I'm just thinking of ways
Oh,
that people will like grasp onto even this concept where you're like, how would a dormant chickenpox virus like sit in the system and then manifest and present itself on the side? You're like, okay, that's called shingles. And
mhm.
like knowing that that happens to a lot of adults, I think it lends itself to this story of dormant viruses and things that are
Sure.
within tissues that are stiff and not mobile.
Well, we talk about the gut's microbiome all the time, but we have this interstitial space within us, our connective tissue, which is it's also has its own microbiome in the interstitium, which we do hang on to junk, right? That we haven't been able to filter out. So we do have stuff that hangs out in our. It's totally normal and natural. The problem is just like our gut. When bacteria starts to, like the bad bacteria start to outweigh the good, then you have problems. The same thing that, well, if you've had a history of the herpes virus or chicken pox, and that's kind of hanging out in there and um, loves to be part of the game that's happening, and then you have a COVID exposure or Epstein-Barr exposure, whatever it might be, it really fires up the entire viral microbiome. So
So, like the classic people that get your common cold and end up with lip,
yeah,
mouth sores.
yeah, the microbiome was riled up. You might have ended up with a bacterial cold exposure, but your viruses are like, "Oh my gosh, thank you for the inflammation. I
We'll
shall
come to the party
participate."
too.
Yeah. Yeah, so and uh, I caution I don't think that we understand fully. Sorry, I know that we don't understand fully what happens with viruses and chronic viral loads and all of that. You hear the argument over what does IgG and, the IgM really mean when we're testing people. I think it's just important to understand that we really don't think that we fully get rid of viruses, that in a lot of people, they do hang out, but we can control the amount of activity that's happening of those viruses. But historically, when I talk about primary issues versus catalysts versus we know that the catalysts out there do seem to be Epstein-Barr and COVID. Just the way that they interact in the body, the way that they get into neurological tissue. But that's where if somebody has a COVID exposure, that's the catalyst to their herpes virus and the shingles that they've had, which could be their primary problem. That's where we can get into some problems when we talk about like the natural type of medicines that are out there that people are just stuck on. Like, no, it has to be this, or it has to be mold, or it has to be like that's. I've treated this for years, and I know that this is going to work. No, it's kind of everything with when you have a connective tissue problem, and knowing that and listening to the patient's story and what they know that they've been tested for or have had exposures or reactions to. That's very helpful. But no, viral loads in the body are going to irritate the neurological system. And if you, using the bucket analogy, if things have been building up with neurological inflammation and it starts to spill over, one of the areas that we do see this is definitely brainstem that happens, which is our primary area for communication back and forth for the autonomics. So, yes, neurological inflammation from viruses do tend to cause dysautonomia events. And I've heard from so many people of my dysautonomia was different after I had COVID. And this is what, like, you have to regroup and again, infinite amount of ways to help stabilize the neurological system and the autonomics afterwards. But you have to work with a provider that knows that it's not one way or the high, like, here's the one strategy I have for you. Nope.
Right.
There's
I
so
wish it
many things.
was that easy.
Gosh, I wish everybody was a protocol, but nope,
And
that's not how
one
it works.
simple like framing like stance that I've used that's been helpful to kind of shake off that stigma around a diagnosis and it has to be this is just like you'd mentioned it already, just dysautonomia, and then I'll call them dysautonomic events, just so it kind of like flicks your light switch of, oh hey, that was like a thing that happened that shifted my autonomics,
Mhm.
and it wasn't like this wrapped in this whole diagnosis, and it has to be this. It just I think it's a little bit more it lends itself to eye opening rather than narrowing or eyes closing and like, "This is definitely it."
Yeah, and to shift over towards that reprogramming piece, um, it I consider this a little bit different. Stress is one thing, and you can have stress from trauma, but with trauma, and it doesn't matter what we think trauma should look like, it matters how the brain interprets it. So people that have more
Like
minimal.
like big T traumas or cumulative little t traumas, is that kinda what you're
Yeah, or even imagine somebody that even has like the small T trauma, but their neurological inflammation is through the roof and
Sure.
their brain doesn't know how to interpret it. They could have a bigger reaction to it. So, with that being kind of layered onto everything, the trauma piece of it does have more of a compensity to reprogram how the brain processes things. And
For
that's
future events.
for
Yeah.
future events, and that's part of autonomic regulation is your brain being able to communicate with the rest of the body, and we can have dysfunction in that when a trauma occurs. So reprogramming is really important at some part with a lot of people of reprogramming how the brain communicates with the body and the body with the brain, lots of different ways to do that, but just knowing that trauma in how it repatterns the brain can also affect dysautonomia and make it difficult to find stable ground to stand on again. So it's about the neural communication. Mhm.
Yeah, I'm a big fan of that word, like patterning. I use it a lot in the space of like biomechanics and strength and kind of conditioning, but definitely with the nervous system as well. Strong in the autonomics in terms of reactions to things.
Yeah.
And what some people would be like, I'm overreactive. I'm like, not for your nervous system. I think you're just reactive. Like it might look as well, none of the humans around me react the way that I do. Right? They don't have a nervous system that's programmed to react as strongly as yours does.
Yeah. And yes. And I think that a lot of individuals out there are good at experiencing things on their own, closed away from other people, whether it's the shame or the guilt or the embarrassment. So I feel like we don't know what other people are experiencing out there. I feel like people hide the fact that they're dealing with things, and we don't necessarily know, who is really suffering out there, who might know or be able
Sure.
um, to share experiences with us. And again, the shame and guilt part of it, because there are on days when I have more neurological symptoms, I am less likely to go out and show people my neurological symptoms. So we don't necessarily know who's dealing with what. And there are just some of us that we happen to have those episodes around other people at times. So it can feel like we're more exposed and experiencing more.
All right. So where do you want to go next? So stress load and kind of uncontrolled situations, viral. Where shall we pivot to?
So let's go to anatomy a little bit. Um,
Talking like uh anatomical differences and changes that can occur.
Yeah, let's talk a little bit about the anatomy just briefly. We'll talk a little bit about hormones briefly, and then I think we should wrap it up because we
Okay.
could talk like all day about this. We're not going to include everything that can cause dysautonomia. So
Sure.
please, I mean, you can ask questions. We love questions, but we're just not going to get to all of it because so many things can cause or affect dysautonomia. But speaking of the anatomy piece, like I said earlier, upper cervical instability can exacerbate or even cause dysautonomia in two different ways, and actually more, but I'm going to name the two main ways. One is that if we have this forward head posture, which happens for a number of different reasons, but if we start to experience some instability of the mid or the upper cervical spine, we basically get a flattening of the cervical lordosis. It puts that head into a little bit more of a forward and extended position. Now, the vagus nerve, as it comes out of that little hole that's there, in the skull, it comes down and it has this really nice pathway with a cervical lordosis, that nice curve, to go right down and drop, behind the clavicle, and it goes into it's a very long nerve into the abdominal space. Um, But when you have this flattening position, you might think, oh, that shortens the pathway. It does not, because it changes what's happening up the upper cervical spine. So instead of coming out of this hole and dropping downward, what it actually does is as the as you're straightening the spine and you have this forward head posture, you now almost give it, in some people, a 90-degree angle to go by. So it's
But
not made to do that. It doesn't
if
like
we're
to
thinking
be.
about nerves, and let's just like any electricians out there running cables and wires, you want things straight
Yeah.
and like not bent at 90 degrees as much as you can.
Right, right. So there's a really good, I'm sorry, I forget the name of the article, but it's a Hauser article from either 2024 or 2025 where it shows this picture really nicely of this forward head posture and this diagram of the vagus nerve and just how it does get pinched in that area. So that's one way, is just the change in the cervical lordosis can exacerbate your dysautonomia. So working on that can be helpful. The other part of it is that that pathway for the vagus nerve, that neurovascular bundle, also very closely sits next to basically C1, C2. So that's the AAI, or atlantoaxial instability between C1 and C2. And if you have a rotation that happens there, it's more likely to compress that neurovascular bundle because of anatomy and where it's placed. So if you have a rotation, it can compress the vagus nerve, which is that bidirectional communication between the body and the brain, autonomics. And if that gets irritated, even in the peripheral area here, it doesn't send good feedback on that loop. So you can give yourself dysautonomia by anywhere along this vagus
Sure.
nerve, including things that are happening in the GI system. So anatomically, and we can go all the way down the chain, it drops all the way down. You can compress it at the diaphragm.
Like going through
So
the
many different
diaphragm,
areas
right?
that you can compress the vagus nerve and exacerbate or cause dysautonomia. Um, but that's from an anatomical piece, and we're not even talking about brainstem irritation and Chiari malformation and things like that that can also cause dysautonomia because the brainstem regulates autonomics. So that's part of the anatomical piece. And again, other things like there's reasons why tethered cord affects the
Sure, you can
brainstem,
go
things like that.
further down the
Yeah, lots of reasons. I always say that's the great thing, is that we have so much to still look into with individuals. And the hormone piece that I do just want to touch on, we do know that hormones are involved. I think it might have been, maybe, forget if it was a presentation that I did or if it's actually in our Taming the Zebra Volume 1 book, a list of the hormones and how they affect the parasympathetics or the sympathetic responses in the body, because certain hormones, depending on which ones they are, do affect sympathetic drive in some organs. So, yes, your hormones can affect dysautonomia events. Absolutely, 100%. And we have seen through, I think there is one case series that was done, that when we had individuals transitioning from female to male and given testosterone, their POTS symptoms got a lot better. And we always talk about this amongst providers. And anecdotally, we see joint pain get better too. That's not in the research yet, I don't believe, but it's at least recorded in this article that yes, we saw that POTS symptoms got better. So we know that hormones do play a role. And I think there's a lot more individuals that are, working with microdosing with testosterone to help. It's still a mop, guys. It's still a mop. But I do like mops. And it's actually an efficient one, but it's very hard to find the right amount for. Um, but hormones can absolutely play a role in dysautonomia. It literally will cause sympathetic or parasympathetic events in certain organs.
Sure. All right. So something I was gonna say about what were we talking just before hormones? Oh, about postural
Anatomy.
piece and
Yeah.
anatomy. Yeah. Um, a lot of work in the space that I do is around like posture and finding tone and safe, kind of like this theme of safe movement that, I'll have somebody that can go and walk a certain amount of distance. It could be like minutes or miles. And my thought is always like, what happens at that 10th minute or that third mile where things just fall apart? Because if you can do any walking, that tells me that like we have a lot of things going for us,
Mhm.
but there's something anatomically that's being overacted on or compressed or pinched that's happening at that threshold for you. And that's always the first place that I kinda tend to start is in that postural stability piece to kinda function, to hit to nod the anatomy stuff towards the
Yeah.
better or the more functional.
Yeah, that's what I don't know what somebody needs for dysautonomia until I meet them. That's why, like, a random knock at somebody's post, you know, it's not valid. I'm sorry. Like,
Yeah, as a
so many
sidebar, we've
things.
been talking about putting some videos out for things,
Mm,
and I always that's part of, like, my catch up is that or the holdup is that it's just not going to hit everybody. So there's some general suggestions, but I don't even use the same base level, like, supine supported. I don't even use the same postural cues from person to person,
right. It's
and it's
so
so like, you need
individualized.
to meet somebody where they're at that time.
Yeah, we're still gonna put some videos together. But I mean, the caveat is always like we're so unique as individuals. What works for one person may not work at all for somebody else, and that's okay. It's just finding the right things to put together. Same with dysautonomia of yeah, electrolytes and water might be helpful. For some people, it might be a reintroduction to anaerobic and then aerobic activity. For some people, it actually might be controlling their stress levels by a cranial stim unit until we can figure this all out.
It reminds me of, like, the video series is out there that are like, "I did I did these 6 things, and now I have no hip pain." And it'll take you through a nice, like, dynamic, you know, "Let me work on flexion and external hip rotation at the same time, and I did this, and I did this." And, like, that could be part of your equation, but I was thinking, like, we could do a series of, like, "I had really bad dysautonomic flares, and then I did this." And it was 50
50
things.
things.
And gave somebody a seizure because we put so many things out there, and they were like, "And now I feel better." But,
It's true though. I
like, that's
mean,
just the work that goes into it's like we've said this before with, some of the patients and providers we know will come across tool X, and they'll be like, "This tool saved me." And you're like, "And all the other stuff that you did up to that tool also
right.
saved you."
Right.
It's
There are things
inclusive.
building up to that. That's what like we can't point our finger at one thing. There's lots of things that can be helpful. And it's usually a combination of finding the most impactful things for each of the main issues somebody is dealing with and implementing them at the same time, hopefully, like overlapping. So it's usually like inflammatory support, neurological health and control. And yes, a little bit of movement in there, like the anatomy piece as well. But how do we combine all of those for like a more complete type of treatment?
Sure. Alright, I think that's a good place to put
Mm.
this boat on land. We'll come back next time with a little bit more of that episode 6, like we were talking relationship and, support for families and
Well, messages for family
messages for
members
family.
messages for family members, in a loving way, but we'll come back to that. We've just had a lot of people come back from the holidays. We're currently
Sure.
in them right now. Um, that holidays can be difficult, for individuals with chronic illness, dealing with family members who kinda get it and don't. So we've been asked to, as one of the things, if we could kind of put together messages for our family members in
It's
a
like the
kind
family
way.
members, it's like, "I understand you," and you're like, "I don't think you do."
Right, right.
Yeah,
So we're
yeah.
gonna
Alright, so that's
try to
space.
yeah, we're gonna
Thanks.
try to
Alright,
revisit
so we'll
that.
be back for that. Thank you for tuning in, and as usual, reach out with questions, comments, anything you'd like us to address in the future. Thanks.
Okay, I'm so done.